Okay, well, thank you, Cindy and Dr. Miranda, for the introduction. Um, I welcome all of you from all over the country, and those of you that are here from New Mexico. I'm in Albuquerque, New Mexico. I'm Rocky Romero again, and trainer for the Mental Health Technology Transfer Center, and have been working with these folks for about 10 years. Today's presentation, I think, is really important in terms of looking at culture as an integral part of mental health services for the Latino and Hispanic populations, or Latinx populations, as now some of the current generation is claiming language use for their definition. And then it's taking definitely a peer worker perspective and application. So I'm going to go ahead and get started. Before we jump into the PowerPoint, I wanted to just get by show of hands, if you know how to kind of operate the polling there with your hand. How many of you are practicing and currently in New Mexico specifically? So just by show of hands. And then the next thing that I want to ask each of you to do, if you can, is in the message box, go in there and just type out where you're coming from across the United States, or if you're in another country, just go ahead and punch that in and send that message to all of us, just so that we all in this group today have an understanding of kind of where folks are coming from, and then we'll get started. So today's presentation, just so everybody's well aware and full disclosure, was initially set up as a series with the New Mexico Office of Peer Recovery out of New Mexico. And we definitely wanted to highlight ways that peers, certified peer support workers specifically, could continue to develop their skill set within a clinical treatment team or within a multidisciplinary team. So that's what the series is going to point towards. Today we'll get into, again, some of what that looks like, but first looking at some definitions and some important aspects of why it's important for peer workers to understand some of the concepts and information we're going to introduce today. So one thing I want to have just clear out is, peer workers, again, we want you to kind of think about this from a perspective of playing the role of an advocate. And then also in the introductory question, therapeutic relationship also came up. So looking at it from those two roles within your role and team member role within a multidisciplinary team. So let's go ahead and get into the presentation itself here. I want to make.
Sorry, I'm gonna let you know more or less the couple of answers we got. So we got people from Texas, Arizona, Massachusetts, California, New York, Florida, Pennsylvania,
Awesome.
people in Albuquerque as well, and other parts of New Mexico, Illinois, upstate, not necessarily from New York, and more or less that's like the whole spectrum of the audience.
Awesome. Thank you for that, Cindy. All right, so moving forward, again, today we want to look at, and this is, just keep in mind, this is a three-part series, with the fourth part being specific to suicide approaches within New Mexico. And I mean, not within New Mexico, but specifically looking at that training was originally going to be in New Mexico physically. Now we kind of get to take this on the road and do it as a webinar. So we're hopeful that that is able to happen in our fourth series. If you need more information, please email the Hispanic Latino Mental Health Technology Transfer Center, and they'll send you the brochures or flyers for the next several presentations. So we're going to look at a few definitions and terms and some statistics to start off with. So one of our goals, again, is to provide an understanding of the current distribution given the populations in the US. We'll also look at some of the characteristics or possible barriers to that service delivery. And again, in the role of an advocate as a peer, also being aware of accessibility and how that becomes one of the health disparities that we're gonna ask you to address and talk about that today in our presentation. And then again, just looking at specifically useful mental health treatment. And once again, in the role of an advocate, making sure that the agencies and the services that are provided to the Hispanic and Latino population as an advocate for that population is provided in a best practice approaches, and is provided in evidence-based models that have been adapted to meet those needs of Latinos or the Latinx population. And you'll hear me kind of interchange those terms as we move forward. So 3 learning objectives. We'll provide an overview again of the stats, kind of looking at the population. We won't spend a lot of time on that, but it's a snapshot. We'll define terms that are useful, again, in service delivery, specifically for a culturally diverse population. And then we'll explain class standards. So cultural and linguistic standards that have been set out by the federal government that are important for you as an advocate to know that you have that legal discourse to stand on if the event happens that clients aren't being served in the language that they speak, if clients are not being served or provided information, pamphlets, brochures, accessibility materials in the language that they speak. Those are things that we have to start to address. So the Hispanic population, as you all know, and this is from 2017, as many of you probably have taken, I'm hopeful that you filled out the census, but that will be coming out here soon in terms of the data, the outcomes. But looking at this from the Hispanic and Latino populations, 57 million, or 18% of the current US population. Of that, 33% are foreign born. So the immigration process, right? And we have to understand, and that's a core part of this presentation today, is understanding immigration trauma as well. How individuals experience the immigration journey that they go on very much indicates if they'll experience traumatic events that will obviously, as you all know, impact their mental health and potential success as an immigrant in this country. Up to age 17, again, is 25% of the population. So we have a really young population that's coming up, and I think those are also things that we have to look at in terms of prevention and also directing our services to that population. 16% of that is, again, age 18 and older, and again, understanding strategies and looking at populations that are going to need, again, maybe more looking at older populations and depending on where you are in your service provision, you know, kind of looking at it from that population's needs. So this just kind of gives you a breakdown again of that spread demographic relative to immigration in the different countries. As we see, Puerto Rico 10%, Dominican Republic, and again, keeping in mind Puerto Rico obviously a part of the United States, so not necessarily immigration in that sense, but there is this ambiculturalism or biculturalism, right, that happens where many people travel between Puerto Rico and the U.S. And I think that's also something that we have to consider. 62% Mexican, and then you see all the other kind of percentages scattered throughout that. So it's important to just kind of keep this in mind as we're looking at distribution, looking at your population, you know, what percentage of your population, and there's these small communities that start to show up within larger communities in the US that are maybe coming and immigrating to that part of the country for whatever reason, job opportunity, economic opportunity, family already immigrated to that area and is settled in the US. So just thinking in mind the home country that many of these individuals come from in considering cultural awareness and appropriate services. Again, looking at the trends or projections, we think about, again, census and what the projection is for 2020, 2050. That gives us some indications of how we as providers have to start to become much more aware of cultural nuances and application of services based on the populations, of course, we're serving. So this gives a snapshot, right? A median age Latinx populations, and this is where you see some of the language start to change of the use of Latinx as opposed to Latina or Latino, right? And many individuals are saying that The Latinx indicates a non-gender binary, right? So with Latina and Latino, you're putting people in a he or she type of situation. Latinx kind of gives us some gender fluidity, if you will. At least those are some of the reasons that has shifted in terms of language discourse. So median age, you see that. Education, no diploma, 31%, 7% whites, of course. Median income, and we see the difference in disparity between median income between Latinx populations and non-Latinx populations of almost $12,000. And that's one of the health disparities that indicates benefits or health outcomes for individuals, right? Is obviously their income and their ability to pay for healthcare, to pay for healthier foods, to have access to services that others in lower socioeconomic status may not have. And then we see the poverty level, huge disparity, 19% compared to 6%. English only spoken, 27%. So a very large percentage of the population is still speaking Spanish at home or whatever their language is of their home country. And then of course, 94% of those non-whites are English only. So again, just another snapshot of disparities, right? When we're looking at health and the uninsured. So making sure that we're, again, becoming advocates for Latinos, given the increase in population, getting access to services in the language that they speak, being aware of what interventions may be tied culturally, and maybe a cultural approach may be more appropriate than a medical approach. And we'll all talk more about that here in just a little bit. So with that number, we see 15% having prevalence of mental health disorders. Now, right now, I don't think there's any indication of that 15%. What percentage is traumatized or has experienced traumatization through the immigration process, through the journey of coming to the United States? Many of the research in looking at health disparities shows that individuals that immigrate to the United States oftentimes come here healthy, and as they get into the system, and many claim because of a system of racism or institutional racism that individuals that are immigrating here experience, they start to develop mental health disorders, other health issues start to come up. And again, that's again, talk for a much larger presentation, but I think it's important to note that as well. So some of the mental health disorders, and again, we see a very large population of Latinos experiencing anxiety and depressive disorders, which, you know, for other populations pretty similar, but I think the key indicator or cause of some of those disorders is trauma, right? Post-traumatic stress disorder, the use of substances for self-soothing and self-coping, self-medicating purposes. We see a huge susceptibility for Latino communities, especially because of the disparities, right? So when people are feeling anxious or in despair, we typically tend to want to self-soothe ourselves in some way. And if there's not coping strategies or a larger support system that immigrants may be connected to, then we know that they potentially may be experiencing stress at high levels. Last point here is, because of, and not just Latinos or Latinx, but we know, again, given the New Mexico population and in this region, many Hispanic and Spanish communities in northern New Mexico tend not to seek out mental health as their first level of intervention, right? They tend to seek out maybe a family member, maybe a parishioner, Catholic member of the Catholic Church, or a curandero, or member of a healing community of that type. So understanding that we're typically last to seek mental health services, given cultural beliefs and practices. So again, just in summary, I won't go through all of this, but we see some of the breakdown of anxiety symptoms, looking at specifically some of the behaviors relative to substances and smoking, and then depressive symptoms. So looking at Hispanic versus Latino, and again, we won't get into this. This is a much larger conversation, but many of you from New Mexico that are practicing there, I'm sure, have had conversations, especially if you're from the Hispanic or Latino population, when families get into discussions about being Spanish or we're Hispanic versus being Mexican. And I think those are considerations that we have to think about when you're meeting with clients directly, and you're increasing the therapeutic alliance, right, by being a peer worker, by understanding where this individual is coming from, whether it's through your own immigration experience, whether it's through your own recovery from addiction or substance abuse and or mental health disorder. That's the beauty that you have as a peer, to bring that connection and help people feel more connected, and understand that you're asking, and part of the intake is getting a sense what they connect more to. Do they connect more to Spanish or Hispanic? Do they connect more to Latino or Latina or Latinx? And understanding Hispanic has become a very politicized term, and was obviously historically created for census and political reasons, not necessarily for ethnic or racial kind of definition. So again, looking at the introduction of language, right? And I'm doing another webinar tomorrow as part of a series out of Rutgers University, that we're looking at the use of language and the language discourse specific to race and racism. And how that plays out in the provision of mental health services. So this slide is just meant to kind of keep us thinking about the fluidity of some of the labels that have been given and are typically, social constructs. So now introducing some of the kind of federal standards. And this is kind of where we start to get into class standards, but the Census Bureau defines Hispanic or Latino as Cuban, Mexican, Puerto Rican, South or Central American, or other Spanish culture or origin regardless of race, right? So just thinking about it from that definition, and let me be clear, that may not be your definition, or that may not be the definition that community members define themselves in your community as. But having an understanding of how they define themselves will also help you determine the appropriate course of treatment and the appropriate course of how you talk to these individuals and connect with them on a personal level and a therapeutic alliance and relationship level. So looking at culture, some of the issues that we want to bring up, or areas that we want you guys to think about as a peer worker, right? And for those of you that are in the audience that are clinicians or therapists, social workers at a master's level, and you have peer support workers now in your treatment team as a part of your multidisciplinary team, or as an agency you solely have peers that are now developing your program through case management, through outreach, through community engagement. We really want you to think about cultural responsiveness, right? So cultural competence is one of those terms that I think we're starting to move out of the way and kind of strike it from things, because there's no checklist or checkbox that you can say I'm now culturally competent. It's an ongoing learning, evolving kind of thing, especially now with society where we're seeing movements of Black Lives Matter and other lives. Having an understanding of those cultures is something that we're just evolving or learning about even in more depth, especially with urban African Americans as well. Right, so cultural humility and fluidity are some of the newer terms that are, I think, more appropriate. And then culturally responsive, so assessing and intaking and doing an intake on what are the cultural values of this individual. And the DSM-5 has the cultural formulation interview, and it's a very easy document to follow. Many clinicians don't know about this, and I don't think that a lot of times it's used to help the multidisciplinary team really develop a culturally sensitive approach in order to develop more successful outcomes because of the therapeutic alliance and the therapeutic relationship that a peer can help evolve and develop fully. So The process, again, cultural, looking at this from a cultural perspective, this is the process in which members of one cultural group adapt the beliefs and looking at acculturation, right? Acculturation can be reciprocal, that is, the dominant group also learns patterns of the minority group or vice versa. We see a lot of times in the immigration of families together or separate, parents first, young kiddos or young people second to immigrate or vice versa. Regardless, many times young people or adolescents are acculturating at a much more rapid pace. That is, learning the United States or ways and values and practices of the United States much faster than their parents or their grandparents. And we have to understand that that creates, in many cases, a communication breakdown between family members, and especially with the use of technology, social media. A lot of times parents aren't so technology savvy or have an understanding of the impact or influence that social media can have. So I bring that to your attention for those peers out there that are working with families and especially teens that have immigrated and are having family dynamic issues. Really understand that acculturation, it means that parents and young children, siblings are acculturating much faster in many cases. So again, acculturation is most typically concerned with an individual and how they relate to their much larger group or subgroup in society, and trying to adapt, trying to fit in, right? If you're an immigrant as a young child or an adolescent from another country, you immediately feel other and different and almost like an outcast. So you adapt ways, dress styles, maybe tattoos, maybe the style of music that you listen to, social practices and social media interaction, in order to try to fit in order to try to become closer to their peers. And you know, peer pressure is still alive and well, folks, and we have to understand that absolutely as we go through this. So assimilation, right? This is a little deeper. This is when a group actually moves into changing their language preference. So not speaking Spanish anymore. I've seen a lot of families go through this where the parents and the grandchildren are very upset because the individual young child or young person, you know, adolescent, is not speaking Spanish any longer. They're only speaking English, even when the parent or grandparent speaks Spanish to them. And sometimes that can cause family conflict, right? So we have to understand the assimilation process creates a lot of waves within the family dynamic, communication, as well as cultural aspects, you know, aligning more with US rather than or opposed to home country values. And that creates different communication breakdowns, as well as some tension and conflict potentially. So ambiculturalism. So that's a lot of what we see, not only with our Latino communities or communities that have immigrated to this country, whether it's Mexican or others. We see this a lot where also our indigenous communities, our Native American communities are also experiencing this, where they're caught between kind of two cultures, right? They maybe spend time and live, you know, back home on the pueblo or on a reservation, but they also spend a lot of time in the city and maybe even have a home here in urban, you know, suburbia here. So looking at it from that kind of view, understanding that people then become confused and maybe conflicted at times, and resolving that for them or helping them resolve that can be very beneficial. That's where I think a peer also becomes very valuable within a multidisciplinary team or within an agency, or even within schools, right? As school-based mental health, having peers that are also leaders in that school can also help individuals that are immigrating and just becoming new community members, school members, can have an easier transition, or at least, you know, be more successful in that transition. I think for purposes of technology, we wanted to embed these videos into the series I'm going to go ahead and just keep it in there. We're not going to play it for right now. Maybe at the end, if I have a little bit of time, because I do have about 40 slides or so that I really wanted to get to. But this is a link for you to go to and a resource for you to visit. It just gives a perspective and young people and other community members perspective on how they experience biculturalism, and it just helps if you're not someone that comes from a minority group or a group that has immigrated to this country, or you don't come from an indigenous or a Native American community, you may not kind of fully understand what that biculturalism experience is like. So the immigrant paradox, right? Being born in the U.S. And longer periods of living in the U.S., how we see that people say and kind of have this idea of the American dream and coming to America and thriving and being, successful. And many times that's what they're seeking is they're seeking shelter from persecution, from violence, from communities that are drug riddled. So we see people that are wanting to come here for a better life, yet many individuals when they come here experience racism, experience a lack of cultural awareness from the systems that they engage with or the institutions that they engage with. So they develop physical and or mental health symptoms and disorders. So understanding that, and then understanding this, that individuals from this community or from New Mexico, let's say, that were born and raised here, third or fourth generation, maybe they did, their family obviously did immigrate here from another country, because at the end of the day, folks, we all have to remember we're all immigrants to the United States, unless we're indigenous to this land, unless we're Native or Navajo or come from this community, we're immigrants to this country. So understanding that kind of historical perspective a little bit, I think will help, address and create a therapeutic alliance, and peers in their role can really help with that, and be that conduit for building connection. So now we kind of look at this from a health equity perspective, right? So, individuals from diverse cultural backgrounds should, and we hope, and that's where your advocacy peers out there, advocacy roles come in. And as clinicians, if you have a peer worker serving as a case manager or in a certified peer support worker role, I think it's really imperative that you understand and empower them to be advocates of health equity. Being an advocate maybe for your agency and for those clients that they serve, to seek the highest level of healthcare, behavioral healthcare, education and housing and other areas that we know, again, through Maslow's hierarchy of needs, right? And I've done training with peers before, and that's one of the theoretical perspectives that I reintroduce, and I'll just throw it out there again here, is always as peers, support workers, I believe, because you're so connected to some of the clients that you're seeing, in the sense that you may have similar experiences, it's really imperative that you're able to see their needs from a hierarchy of needs. And Maslow's hierarchy of needs really presents that, right? The very basic level, if we don't have safety, security, shelter, home, food, nutritious food at that, let's not just say food, because junk food comes into play. That's where we become advocates as peer support workers. And clinicians, that's where you can use peer support workers as those advocates, as those team members that seek that. And this was always a good illustration, right, of kind of ways to think about that. So take a couple of seconds and look at that, especially if you haven't seen that before. So part of what we're seeing is that if you look at this from a perspective of equality solely, that means that everybody is starting from the same starting point, right? Typically, you won't get equity from that, right? And that's important to understand, because many groups, since the end of our kind of years in war here in the United States, end of the late 60s, early 70s, policies were put in place to benefit certain dominant groups within the United States and within the country. So the starting line has never been equal from the beginning, right? So if we're looking at equity and health equity, we're giving people boosts that need a boost. We're advocating for groups and populations that maybe historically have been treated less than or have been excluded from access to services, or maybe resource-wise, their community has never seen dollars go into their community for development of their health clinics, of their libraries, of their schools. So that's where this definition of health equity comes into play, and we really want you to hopefully focus on health equity rather than equality. Health disparities, and again, it kind of goes to this last illustration, but looking at the 2020 Health People defines health disparity, or healthy people, I'm sorry, a particular type of health difference that is closely linked with social, economic, and/or environmental disadvantage, right? And that's where we talk about, and the whole discussion around race and racism becomes one of those links potentially that you can include in social, racial, even economic and/or environmental disadvantage. So just think about that in terms of that definition. We know that health disparities and come in many different forms, whether it's institutional, social. Hispanic and Latinos are underrepresented in professions related to behavioral health. And NALBA and you know their group really in New Mexico, for those of you that aren't aware, the National Hispanic Latino Behavioral Health Association, they give scholarships for young Latinos or Latinx population members that are seeking to go into a behavioral health field, and they'll help support you through seeking your and finishing out your degree. So we have some again, access is hindered, again, in terms of the definition of disparity. Access is hindered by the fact that significant number of Hispanic and Latinos are uninsured. And of course, that's a whole bigger political and policy discussion that we have to be advocates for as peers and as, again, members of the behavioral health community and profession as well. So many of the policies that have been created over the years, especially when we look at immigration policy or lack thereof, a solid immigration policy from our federal government, we very much see reduced access to services, lower retention rates, whether that's education and/or once intervention and treatment is provided, sometimes retention isn't really accomplished, and that's for many different reasons. Looking at it from support systems, maybe the agency or the institution is not culturally aware and sensitive, and the client terminated services early, didn't feel connected to your agency or to the individual that you're working with. So peers become that conduit for a successful relationship. Absence of effective community strategy. So just like I mentioned, ineffective policies or strategies by a community-based agency or institutions or schools can very easily lead to early dropout, less retention of behavioral health intervention and skills that you've tried to teach because of early dropout, and again, hence creating a lack of retention. The disparities in the workforce, you know, looking at Hispanic leaders comprise only 11% of the behavioral health workforce, even though a much higher proportion, again, of the population is needed for those services. And we hope that in communities where it's able, that services are provided by community members that also reflect culturally and linguistically and potentially racially the clients that they're serving. And we know that that's not always the case. So for those of you that are
We're sorry. It seems Dr. Romero is having some issues. We're gonna be checking on that. So give us a couple of minutes. Thank you.
Okay, I'm sorry about that, folks. I think we're back, or I'm back. I think I was the one that disconnected. So let me just make sure that you all can hear me now, and we'll go ahead and go forward here.
Rocky, I just gave you all the access again.
Okie dokie. Can you hear me okay now and see me fine?
Yeah, your webcam is off. Let me see. Well, we can hear you fine.
Okay, there we go. Sorry about
There
that,
you
guys.
go.
Okay, I'm back. So again, I just want to kind of reiterate, making sure that we're on the same page. Let me bring up the presentation one more time. Here we go. So the class standards again, and we want to make sure that folks are just understanding this from a perspective that is, that more importantly, the application part of it.
Yeah, that's where we were. I just wanted to share that's where we lost you. I don't know if it was at the end of this slide, but that's where we lost you.
Okay, perfect. I'm going to start here. So just in summary, again, looking at the behavioral health workforce, making sure that we're trying to mirror the populations that we're serving, if not helping to support your agencies, and that's what we're here for. The National Hispanic Latino Mental Health Technology Transfer Center is here to provide free technical assistance and training to your communities and to your agencies if you reach out to us and need that. So looking at class standards, more specifically, standards for culturally and linguistically appropriate services in healthcare. And again, this is a federal mandate since 2013 that requires any agency providing services to populations, and again, cultural and linguistically does not solely mean Hispanic and Latino populations, right, or Latinx populations. It means any population, whether that's individuals needing Mandarin or needing to be aware of culturally appropriate services for our Chinese or our populations from Central Mexico or specifically certain groups, right? It means all individuals that need cultural and linguistic appropriate services. So let's just be aware of that. So the standards, there's 15 of them. I'm not going to go into all of them, but effectively, they kind of provide a template for you to use in order to be an advocate, right? As a peer support worker, being an advocate for services. So providing effective, equitable, understandable, right, and respectful quality of services and services that are responsive to diverse cultural health belief and practices, preferred languages, and health disparity. Health literacy and other communication needs. So thinking about the three broader themes, there's one that kind of looks at the governance, leadership, and workforce. For those of you that are kind of working in the administrative end, theme 2 is looking at communication and language assistance. So those of you that are working directly within access to services that may need to access translation services through Medicaid or another insurance provider or a third-party entity that you may need to have your agency pay for linguistic services. And then again, ongoing kind of research or outcome through engagement, continuous improvement, and accountability. So those are the three broader themes that the 15 kind of specific standards fall into or break down through. So we want to now start getting into, and we have about 15, 20 minutes left, and then we'll end our presentation for today, or at least on my side. And if you all have any questions, we can entertain a few questions before we end today, and we'll allow Cindy, if there's any follow-up polling questions, to do that at the end as well. So I hope you've gotten the theme of our presentation today is really as a peer worker and as a clinician who has a peer worker as part of your multidisciplinary team, is to know the role within a multidisciplinary team of that peer support worker. Be very clear in the definition of what that looks like, because what helps with that, also with peer workers that I've worked with, we've also helped them to create a professional development plan. And in that plan, we help them outline any specific trainings that we want them to follow up on. If we're seeing blind spots or areas that they need to develop better skills in or more understanding of. And then it also helps them to kind of outline their 5-year plan in terms of they want to seek further education. They want to just go for more continuing education and professional development. So I encourage, those of you that are a supervisor of a peer support worker to consider that professional development plan. And if you're a peer support worker, I encourage you to start, if your agency doesn't do that or support you in that, to develop your own. And you're more than welcome to reach out to me if you want kind of an example of that. But it's a very basic plan that outlines strategies that you're going to take or steps you're going to take to increase your professional development, whether it's through education, professional development, and or in-house trainings through your agency as well. I always think that, and I should have put that as another bullet here, supervision is key to having a successful peer support worker team and outcomes with clients, in really providing them support, ongoing supervision, and helping them develop as a professional and a team member within your multidisciplinary team. Like I've said throughout the first few slides here, be the conduit for familiarity, respect, and personalizing experiences for those workers or for those clients that peer workers are serving. Serve as a facilitator of services and advocate for clients while balancing your role as a professional member of the team. So let me explain that briefly. Sometimes as peer support workers or as a person in recovery or as someone who is really aligned with a certain population because they've experienced similar journeys, right? Whether it's a certified peer worker that has experienced homelessness, and they really feel connected to that population. Sometimes when you're early on in your career as a certified peer worker, you become really aligned, and sometimes it's called enmeshment, right? Or enmeshed with a certain population because you feel that alignment with them. You feel that connection. So sometimes it becomes an us against them, where you feel more aligned with the client. So you start to kind of go against, in a degree or two, your agency, and using terms like, oh, our administration, they don't understand it or they don't get it. Well, you start to create division within your team, right? You can align and still understand and agree with your peer worker experience and the clients you're serving, but you still have a commitment and ethical duty and professional responsibility to also be a member of your team and your multidisciplinary team or agency, right? So you have to find a balance to both of those. And I just say that because I feel that's an important piece where I've seen peer workers sometimes alienate themselves from the agency and the team because they're aligning more closely with clients. And I'm not saying that that's a bad thing, but you have to develop skills and boundaries to be able to kind of balance both experiences. You have to look at client approaches from looking at it from religion and spirituality. Just some bullets to think about. Some religious leaders tend to be connected to larger communities and are usually community leaders, right? Connection with other Hispanic and Latino communities. Sometimes spirituality inspires hope to clients and patients. We have to respect healing approaches that may be different from our own. And that's why we include religion and spirituality instead of just saying religion or locking it into that. We could also use traditional healing and add that as religion, spirituality, or traditional healing. As number 4 here indicates, respect for traditional healing approaches, and really understanding how that impacts your clients and why, if this is an important area that's going to help them be inspired or be hopeful or have some connection bigger than themselves, right? Some mental health protective factors that we see, including concepts of involving the family, but more familia or familismo, right? Clear roles within family and expectations. So that's something that a peer support worker can help the clinician really start to facilitate. Sometimes a peer worker that may be going into the home or doing home visits may have a much better picture of what the roles are in a family than the clinician who may be seeing the family once or twice, or once a week, or every 2 weeks, or once a month for therapy. Peer support worker may have a much clearer picture of what that family dynamic is like. Definitely developing the interpersonal relationships during this interview and intake process can help the clinician, and I believe help the bigger therapeutic relationship to the agency develop with clients. And then trying to understand the family view of mental health conditions and or substance abuse addiction is very important. Showing respect. So this is in general, right? This is one of the three core genuine or core conditions that as social workers we are taught, but mostly looking at it from respeto, right, or a Latin kind of approach to this, Latinx approach. Respect is important in all cultures, right, in some form or way. And at the very basic nature of human beings, respect is very, very important. For Latinos or the Latinx populations, there's different respect, obviously, that's given to professionals versus non-professionals. So at times, don't be turned off by a client or family member thinking that they have to get out of the way of the agency or you as the clinician or peer worker because you're a professional and they don't want to interrupt the work that you're doing with their family member or their loved one. And sometimes we have to do our best to help define that for them and say, no, it's actually the opposite. We see you as a very important part of this intervention, this strategy or plan with your family member. So you're giving them a warm introduction that goes to bullet 3, that is directly addressing engagement and the therapeutic process. And I believe that many times peers can do a lot better of a job than maybe even me as a clinician that doesn't see the client as regularly as the peer support worker or the case manager may do. So that's an important concept of respeto. Personalismo, or getting personal. So looking at this, where we enter into very personal realms of discussion and conversation with clients. So being tactful in your approach. In northern New Mexico and in New Mexico, we talk about it as platicar, and or having cafecito with a client, meaning that before you get into the 10-page assessment and intake and asking them all the personal questions, you spend maybe 5 or 10 minutes just talking about their journey. Where do you come from? Tell me about your family a little bit. Do you want a little coffee? And let's have coffee together, or tea or water or whatever the case, right? But spending a little bit of time for engagement will increase the success of your engagement and the therapeutic alliance, not only for you, but for your clinician and the broader multidisciplinary team at your agency or institution. If the providers can demonstrate simpatia or sympathy, kindness, and are friendly, like I said, we increase the likelihood of compliance. A non-threatening, motivational interviewing approach to things, right? Collectivism or community, right? So an emphasis on community development, group activity, rather than the medical model of individual client in front of me and that's all I see, that's all I address, that's all I treat. We have to look at the broader systems that are involved: family, community, spirituality, traditional healing, schools, whatever other community entities that families are involved in. A shared sense of responsibility, and I'm sorry, there's a typo there, concept, sense of balance or harmony within collectivism and interdependence, right? So still having them create an interdependence of responsibility, self-reflection, but bringing that to a larger community-based kind of connection is important. Now we look at traditional gender roles within the Latinx communities. And keep in mind that this also may apply when you're looking at indigenous communities or Native American communities, when we talk about more of patriarchal versus matriarchal family systems. Many pueblos and indigenous communities operate more on a matriarchal system, right? In many cases where roles are shared between family members. When we engage indigenous communities or community members in an agency, we typically try to approach it from a patriarchal approach, because that's typically the way the United States runs. You go to the man, you shake the man's hand, you look the man in the eye. Well, that's different in many communities, and we have to think about that. Very similar in the Latinx communities, Latino communities. Machismo and Marianismo. Machismo can, let's be very clear, can be a protective role that a male typically fills, but it also can be a controlling role, and sometimes a violent role that leads to domestic violence. So we have to understand that, and can't always just say, oh, that's machismo, and chalk that up to all the negative attributes. But there's some factors that many individuals that do fill themselves in a machismo role are very hard workers, are providers, will work 2 or 3 jobs to make sure their family has what they need. So we have to understand that there's both protective factors and maybe risk factors to each of these gender roles described here. Marianismo, again, the expectation that females will take on, Virgin Mary-like demeanor and or the role of the caretaker. And I think more in our communities, especially those that may not be so much connected traditionally or religiously, it's more the mom or the mother figure in a caretaker type of role, right? Especially now we're seeing a lot of grandmothers raising grandchildren, and bless my mom's heart for being a grandparent who is raising our great niece and doing a great job, but at times still developing and knowing what it's like to have a kid in the 21st century, 20th century, right? So just understanding that. So on outline for cultural formulation, and this is just if you're looking at it from kind of eco-mapping your family system or doing genograms, the cultural formulation interview that is a part of DSM-5 is definitely something that's helpful. It can help create or understand cultural identity. It'll help create explanations for illness. It'll look at cultural factors related to psychosocial environment. So again, looking at it from a biopsychosocial spiritual perspective, and then cultural elements of the clinician relationship will start to develop. In a peer support worker, I'm telling you, if you haven't had a peer support worker in your agency, I would encourage you to start to look for funding, develop that role or that job description, and start to recruit, because they can definitely help you in developing that relationship. And developing that initially at the beginning, as a member of your team. And then the overall assessment, right? As we're going through, we always want to provide ongoing outcome data and evaluation on what we're doing with the clients, and is that working? Is the outcome successful? How are they doing with the interventions that we're providing? These are some other scales that we wanted to provide. So critical self-reflection becomes another skill that I feel peer support workers, as well as providers and clinicians at all levels in a disciplinary team, multidisciplinary team, should do in order to always be growing as a provider. So there's 3 links here that look at doing a self-assessment. So it's a questionnaire that you take confidentially, and it helps you really develop an understanding of where your blind spots are within cultural awareness, bias, race and racism, etc. I think as supervisors, for those of you that are supervising peers and or clinicians, this is a great tool for you to use, or great tools or menu of choices for you to select from in order to help your clinicians get better and be more aware of biases that they may bring to the table as well. Lastly, in closing, again, here's our information, and we're right at 10 o'clock. So I think that's the first time in history, at least in the history of me doing webinars, that I am on time with kind of ending things. So I'm going to go ahead and turn this back over to Cindy and our moderators and see if there's any questions that people may have of me at this time. I'm going to go ahead and I'll send out my email address to the group just so folks have it, and I'll just say it out loud in case you want to write it down. It's drjrocky@gmail.com. So drjrocky@gmail.com, and that's an email that I use for my work with the Latino Hispanic population trainings as I go out and do these different community-based trainings. Now that we're using webinar, you know, we're trying to do things a little bit more through a you know, Zoom or telebehavioral health kind of approach. I hope that you all join us for the next 3 sessions that we'll have. If you need more information, please go to the website that's noted in the presentation and or contact me, and I can get you those flyers or brochures. And we're having one every month for the next 3 weeks, including today, 4 weeks. I believe all at the same time, 9 to 10:30, and they're all, I believe, the second Wednesday, or right mid-month of each of the months. So thank you again. Cindy, I'll turn it back over to you, and we'll see if there's any questions. If not, we'll go ahead and end for today, if that's appropriate.
Thank you, Dr. Romero. We do have a couple of questions, so I'm going to go ahead and start with the first one.
Sure.
This one's related to some of the statistics that you gave earlier in the presentation, and someone asked if you have a breakdown of 18 till 24 years old, specifically college age students.
You know what, I can kind of look for some of that, and if somebody wants to provide us with an email address, I can get you that. But I'm sure you know this, that the 18 to 25 age group is typically a very hard group to get data from, because typically they kind of disappear to a degree after 18, whether they move out or move on, graduate high school, so they're not kind of in a collected type of setting where we can access that data. But you know, the youth risk and resiliency studies or YRBS studies that have also been done, and you can just do a Google search of that. They have them specific to New Mexico schools, which is really cool, and it goes up to 18. Now, I think we can make some general projections of the 18 to 21, 20, even 25, honestly. Looking at brain development is still happening for that age group. So we see a lot of individuals, especially if they've had early onset of drug use, sometimes that developmental stage may be delayed. So they may be functioning age 18, but functioning at 15, 16, 17 or earlier. So some of that data, even though it ends at 18, is still, I believe, relevant for that population between 18 to 25. But if you leave us or send Cindy your email address, she'll pass it on to me, and I can see what I can find in terms of more appropriate data for that specific age group. Tough population to survey though, but we can see what there is at least from our work. Thank you.
Thank you, Dr. Romero, and she already gave us her email, so I'll make sure I'll pass that.
Thank you.
Our next question says, what are the best non-Western treatment modalities for working with culturally Latinx or Hispanic communities?
So non-Western, good question. So I think really a lot of, if you've ever read, or if not, I would really look at it, even just get a couple of articles of Paulo Freire and his work, looking at a community-based approach. He also has a book that's called The Pedagogy of the Oppressed, which really starts to get into definition and ideas of how we should start to treat community members more in their own community, right? And that meaning that in community-based kind of treatment or community learning, community type of engagement, I think those are really more productive Now you see Bernalillo County at one time, and I think the New Mexico State Police actually is starting a community engagement team approach, where that's, again, clinicians or peer support workers teaming up with a licensed clinician or law enforcement officer and going out to calls that are behavioral health or addiction in nature, as opposed to sending out law enforcement or fire. So I think those are a couple of strategies that can be very beneficial for your community. I think when you're looking at it from culturally based approaches, stay tuned to the next 2 or 3 sessions that we're going to have, because we're going to talk about some of those approaches much more in detail, and I hope you stay tuned. So that's my little teaser for you to come back and get more information from us next month. Again, but if it's something you need immediate information, send us an email. I'll get you some other information. But again, it's Paulo, P-A-U-L-O, Freire, F-R-E-I-R-E. And if you look up Pedagogy of the Oppressed, or even just do Paulo Freire, it'll bring up several different publications that give you a community-based approach, especially for working with oppressed or immigrant populations.
Thank you, Dr. Romero. I'm actually looking at the book right now so that I could copy and paste that on the chat so it's easier for everybody.
Perfect, thank
Some
you.
people were for the name again. There
I'm
you
glad
go.
that reference out to folks. It's a really good book, and honestly, it does help just understanding, you know, if you're somebody that doesn't come from a immigrant population or has never had any direct contact or work with that community as well, it just gives you a different kind of lens to look through rather than solely kind of a medical model. It's not medical at all, it's community based, and I think just integrating that approach can help a lot.
Thank you. And then the next question, I remember earlier as well, you mentioned a program at a university that helped Hispanic and Latinx youth to finish their degrees. If you can repeat the name of the program or university.
Sure, it's NHLBA, so NHLBA, and they're actually through the ATTC. You know, here in New Mexico, they're the, I believe, the housing agency for the ATTC, and they will actually provide scholarships to young Latino aspiring behavioral health professionals to get their degree, and help support them through practicums and other things. So it's called the National Hispanic Latino Behavioral Health Association, so NHLBA. And that's with Mr. Fred Sandoval, my compadre.
Thank you again, Dr. Romero. Okay. Next one says, why the difference in mental health outcomes between Puerto Rican and other Latinx subgroups?
Yeah, I probably am not the best to answer this question, and I'm not sure if we have one of our other members of the team on the call that maybe kind of understands that a little bit better. But I'll take a stab at it. I think from my perspective, I think there's still some differences relative to kind of the belief systems that are in play relative to behavioral health and even medical. And I think we assume, just because, again, Puerto Rico being a part of the United States, that they just have fully acculturated and adapted all beliefs within the United States, which is not true at all. And I think that's a protective and a strength that Puerto Rico has as a country, is to keep some of their belief systems intact and in place and preserve those so that it does not totally shift to a medical model and a Western model. And then I think too, potentially, given some of the lack of access relative to socioeconomic status and the way that, and I'll be political here for a minute, the way that our federal government has hindered their evolution, especially after some of the disasters and how our president has not supported Puerto Rico through some of these hits that the island has taken is really a travesty. And I think it really puts more kind of separation between groups looking at it from Western United States. But that's just my interpretation, my experience of talking with folks and having friends and colleagues, obviously from Puerto Rico. But anybody else on our team that feels there's maybe something else that's missing there that I missed? Okay.
I don't. Yeah.
So, so and no, that's okay. And then again, I think too, just for you all, just keep in mind for if you want follow up on that question, I'm more than willing to give a phone call to a couple of my colleagues in Puerto Rico and just kind of get a better sense from clinicians that are there firsthand rather than me that gets to travel to Puerto Rico a few times a year and blessed to do that. But next question, please. Thank you for that.
Thank you, Dr. Romero. You mentioned somewhere, I think at the end, something about insurance that pay for terapeuta holística and psychiatrists. And someone asked if they do pay for both because what they heard is that you either cover one or the other.
Yeah, no, I believe I believe it's one or the other as my understanding. I'm not the best at Medicaid reimbursement, so please don't quote me on this, but I do believe that in most cases it is kind of one or the other, and I think that's part of the advocacy part. Now in New Mexico, and I think that's one of the good things that's happened over the years in New Mexico, we've had a huge advocacy group advocate that traditional healing services be covered by insurance as well. So when they negotiate state contracts within New Mexico, and I've been removed from the billing part of things for a few years now. So again, I think you'd be better at reaching out to someone that's more of an expert in that area. But that's kind of the one of the disparities, right, that we start to see in communities that are more rural. They may not have access to a psychiatrist, or vice versa. They may have a lack of even behavioral health services in their community. So we as advocates in communities that don't have that, even to insurance providers and to our state entities, have to advocate for changing in those rules so that our population, the Latinx population, and that's again solely what I'm speaking about today, but even our underserved population that are experiencing lower socioeconomic status, poverty, homelessness, etc., should still have access to psychiatry as needed. And again, so doing the research in your own community I think is important. So don't quote me directly on the Medicaid billing portion, but it's definitely important to know what you are able to and not able to do. I think we have time for one more, Cindy.
Yeah. I wanted to read something and then I'll make you the questions because somebody shared another info on scholarships offered through housing programs for residents with HUD subsidies. And I don't know how to read some of the agencies because they are like a lot of different letters that may not pronounce something that I can read, but I just added that to the chat so that everybody else can have that info. And then the last question I'm gonna be asking is about peer plan. You spoke about it earlier in the presentation and they want you to speak a little more on it, on peer plan early.
Oh, sure. So I think I think the question is referencing helping peers to develop a professional development plan. So with that, what I mean is really looking, and I think the the critical self-reflection slide where we have those 4 links for a critical self-reflection survey that individuals can take. I would encourage you as peers to take all 3 of them if you feel like it'll be helpful to you, because that can serve as a starting discussion with your supervisor at your agency to where there's areas that you need to develop further, and that's specifically around culture, right, and racism and bias, prejudice, those areas. I think it can also help within that feedback that you get about what trainings, professional education, and/or professional development you need to take in order to address some of those areas that you're needing, further development in. I think the second part to that should be your plan as far as what your agency wants you to accomplish within a 3 or 5 year kind of window, and you can start with 1, 3, and 5 year kind of goals that outline, are you planning to move up within the career ladder? Are you planning to stay within a peer support worker throughout those first year, 3 years, and 5 years? Within that plan, I think it's important to have the agency outline what trainings they're going to provide you as a worker within their agency around culture, around treatment, around prejudice and critical self-reflection, around culture, all those areas, right, that agencies typically train in. And then what areas do you as a individual peer support worker want to develop for yourself? What are you looking at developing? Do you want to become more proficient in assessing for suicidality? Do you want to become trained in QPR, right? Question, persuade, refer, as far as a strategy for suicide intervention. And then the last one, so there's 3 sections to that, and I'll reiterate those. The third section should be, what is your self-care plan, right? And not just throwing out self-care just as, well, do you take care of yourself? Are you doing okay? Okay, fine and good. No, listing, what are your self-care strategies? 1, I walk 1 mile a day every day after work. Or 2, I practice mindfulness or meditate once a day for 10 minutes a day before I start my day. Again, making these goals measurable like you would a treatment plan or an education plan, and really having the peer support worker define what they're doing to take care of themselves. And if they are not doing things, you as a supervisor, a clinician, provider should have strategies in your back pocket that you can help throw out to them. And I think that self-care plans and strategies have to include nutrition and exercise. What are you putting in your body? How are you staying active? Are you moving? Are you staying sedentary? Especially now with COVID, we're behind Zoom, we're sitting in our chair, we're in our office for hours and hours, and then we don't get out of the house a lot of times because of quarantine and other things that are going on right now. So I think those 3 areas, one is professional development through education and looking at critical self-reflection through doing some of those intakes. The second is, what are other in-house trainings that we need to get this peer support worker through documentation, through electronic medical records training, HIPAA and confidentiality, duty to report, all the trainings that we give peer support workers up front and/or other clinicians or providers. And then the third area is a very clear self-care plan. Third section, self-care plan that outlines specific strategies, and you talk about that during every supervision session, or at least every other. What are you doing to take care of yourself? What are you doing to stay positive, hopeful? All those things that we talk about with regard to a full human concept of whole mind and body. And I think that's it. Cindy, any other pressing questions, or are we ready to end for today?
No, we're good. I just wanted to thank everybody, and I added some info that people kept asking about on the chat. Also, the link for our survey. So we appreciate everybody here, and info on the certificate as well, because I know some people ask about it. So everything is on the chat. And I think that's it. Thank you, Dr. Romero, for such a great presentation as always. And if you want to say something else, if not, then we're good to go. And I hope everybody had a great day.
Yeah, thank you again, everybody out there. I'm thankful for those from New Mexico that joined us. Pass on the word, and the next series will get more in depth in terms of strategies, working directly with clients, and again, self-reflection stuff. But thank you for joining us today. Be safe out there. Take care of yourself, and we'll see you next time. Bye-bye.
Bye.